Back for my hammer toe lecture. I've got a timer set because I went a little over on my other lecture. Um, Let me start my screen up here and try to get this through this quick. And I'm calling this hammer toes really because what else can you know about hammer toes, right? I am going to mention some products in here. I have no financial interest in any of the material that I'm going to present today. But here, look, we're not going to do one of these, right? We all fix hammer toes. We've been fixing hammer toes for a long time. We're not going to give you the resident lecture about intrinsics and flexor stabilization and substitution. I'm not going to read from a Glamry. Uh, Here's what you're all asking, right? What's Giordano going to teach me that I don't already know? I've been fixing hammer toes for decades, right? I know what I'm doing. Well, you know me, I always like to find something to talk about. And hammer toes have been around for over a century, right? Here's the oldest article that I could find. It's from the British Journal of Medicine in 1893. They were talking about hammer toes way back then. And this is an interesting article if you can pull it on through PubMed. It's great. Here's another. This is kind of 1931. There was a big lag in hammer toe papers from that first one to this one. But once again, this is 1931, and here it is right here. Frequent visits to the chiropodist for attention to corns and application of felt pads will be required. That's where we were. But here's Dr. Higgs talking about amputation of a hammer toe is to be condemned. If, as usual, it is the second toe, then the development of a hallux valgus is inevitable. I think he probably meant that hallux valgus came first and then the hammer toe came, but they did not like amputation. And here's just a quick case of mine. This is my patient. She's a rheumatoid arthritic patient. She had bilateral foot surgery from two different surgeons. She said nothing went right. And this is her x-rays. And I think you can see this all started with the hallux varus, right? The bunion became overcorrected, a negative IM. The great toe started to pull. She had MPJ dislocation, that comes next, and retrograde pressure on the plantar aspect. And it should have been the second, but look at the arthrosis at the second MPJ. So this is what she's got. And this surgery was in August of last year, but this lesion is horrible on her. There it is right there. It's hemorrhagic. It's not great. And this is what I did. I amputated her third toe. This was 2 weeks post-op, and her lesion's already getting better. What else would you have done for this potentially? This is perfect. You're gonna cut this lesion out plantarly. You're gonna do some other bone work on her. This is 2 weeks. This is from pre-op to first post-op. Here's her missing toe. Got her from this to that. You're gonna fix this with a wile. You're gonna fix her plantar plate. What are you gonna do? She's 75 years old, right? This fixes her, and she's happy as a clam, and the lesion's gone. And this is her other foot. She had issues done on both sides. If you can see, that second toe is tucking under her great toe. It doesn't even look like it's there on her AP view, but there it is right there. And I told her and she had a nasty surgery on her third toe there. I told her if anything needs to be done, we're going to amp her second toe on this side, but she's asymptomatic. So here we're going to talk about hammer toes now. And in preparation for this, I asked myself a question. I said, I think we take hammer toes for granted. When's the last time I dug into the hammer toe literature? And the answer was, I don't know. What's happening? I'm not sure what's going on in the last few years. So here's what I did. I kind of looked at hammer toes 3 different ways on PubMed. I did it with hammer, then toe, 2 words. I did it with 1 word. I looked at lesser toe. There's hundreds and hundreds of articles that come up. And this is, of course, from the beginning of time, but clearly we don't need the 1931 and the 1893 info. We need what's going on right now, right? And, when you look at this a couple different ways, like I said, there's a lot of information, and in 2021 there were about 18 pertinent articles. So I'm going to kind of review some of these things. And once again, the plantar plate's an entirely different topic. Of course, hammer toes play into this, but we're not going to talk about predislocation and metatarsalgia. It's an entirely different lecture on its own. And let's just talk about hammer toes. But here's some of the articles that you get from, and I hope you all appreciate that I cut and pasted all these small, I'm just teasing, of course, but I cut and pasted all these small little things to show you these articles here. And when you look at hammer toe, some really weird articles come up. Look at this Kevlar-based triboelectric nanogenerator and Townes-Brock syndrome. This is some of the stuff. So these aren't all papers that are relevant, right? So that's how the hundreds get down to, a few. Here's our first article. Once again, I have no conflict with these companies, but this was in 2021. This is a fiber reinforced fixation, and I happen to know Luke Ciccinelli pretty well. What a nice guy. He was a Tucker grad, and Luke and I see each other at ACFAS every year, and he practices in Spain. And he's always told me, in Spain and in Europe, with the way healthcare is, you've got to kind of have a one and done type procedure. So they tend to like some of the internal fixation. I know he's really liked the Arthrex Trimmet pins that are out there, because it avoids another surgery. Anything you could do to keep people out of the operating room a second time, potentially. But this osteofiber is a biointegrative fiber reinforced implant, and it actually becomes bone. And they did a retrospective study on these. There were 24 patients. They were so they looked back at the patients that that had these, and they enrolled them. And there was a clinical exam. There was patient-reported outcomes, radiographs, MRI, and they basically looked at biointegration, how quickly these things became bone. And this is from this company. This is a screw. This is not the hammer toe implant, but they make a bone screw. So once again, I remember if you remember a couple years ago, or maybe last year, I did that surgery on first MPJ fusion, and I had a patient with a horrible nickel allergy. This is a screw that can be used for I guess a first MPJ fusion, Austin bunionectomies, certain other types of Liz Frank's fixation for certain things where you don't want to maybe remove a screw, here's this little implant here. Okay, it becomes bone. Only bone remains, they say, at 24 months. There's our pack to insert it. And Luke loves scarf osteotomies, so because they do well over time, and they're easy to fixate, and they have access to a lot of these screws. But you could see in that second hammer toe, there's that osteofiber. It's integrated right into the bone, and they looked at these, and you could see them on MRI. It's a pretty cool little procedure. These are made in Israel, actually. Here's the insertion technique. And they had a fusion rate of 92% at the PIPJ, which is pretty great. All 24 patients showed some surrounding tissue around the implant, which didn't get integrated, but it was not clinically an issue, and there were no cysts. There was mild bone edema, and they had really satisfied patients. Okay, now these guys are some consultants for osteo, so you have to remember that there theoretically could be a little bit of a bias going on, but they had satisfied patients. Here's another article from 2021. Dr. DiDomenico, who practices in Ohio, I've heard him lecture before that he hasn't touched the osseous structure of a hammer toe in 20 some years. He does these Hibbs procedures where he does the tendon transfers, the Hibbs Girdlestone type procedure, and he fixes hammer toes, and I guess that's fine. I still like doing some bone work. You see that little nick on the side of the heel there? That is by the way, he hasn't done any osseous surgery. You can see the massive. Now, I don't know if you're into making an incision like that to fix hammer toes. He does a lot of Lapidus hammer toe repairs like this, and incisions heal from side to side, not lengthwise. But I don't know. I don't know if I want to do this. But there's that was that surgery. There's that little nick right there. He does a percutaneous calcaneal displacement osteotomy. Kind of cool. He uses a giggly saw to transect the rear part of the calcaneus. I know some of my colleagues are now doing these with these burrs, but nothing's cheaper than a giggly saw. That thing's probably $10, and he does these. That's right from the article, and he gets good results with that. But once again, all that incision for hammer toes, I'm not exactly sure. Here's a really cool article from 2021. They looked at relative strengths of different fixation techniques for intramedullary K-wire. So these are all buried K-wire, and they looked at one straight, they looked at a bent, and they looked at two right, all inside basically. And what they did was they fixed them, they potted them, they put them on a machine, and they stressed them and broke them. And all three of those did well. And the thing that I get from this is not a lot of us are doing, several crossed ones inside, but they get good strength with a single buried K-wire. And some of us do those. Now, whether it's threaded or straight, I would imagine that you could, carry some of that data over to the other. But these were threaded K-wires. But if you are doing one IM K-wire, it's okay. It's commensurate to a couple, and it's commensurate to one with already a bend in it. And I don't know how they bent a threaded K-wire. You ever try to bend threaded K-wires? They don't bend very easily. They typically break, but in any event, they got good strength with all. There were no statistically significant differences between the two groups. So if you're bending K-wires, I thought this was a good article to show. And then the final article of 2020, which was, kind of came up right at that hinge between 20 and 21. And this was an interesting article I wanted to talk about. They looked at a smart toe. I'll tell you what a toe grip is in a minute versus a buried K-wire. And I have nothing against any particular intramedullary implant, but I do know that I personally have seen some implants have more problems than others. And I'm not mentioning any names, but to take them out is a bit of a bear, and we'll talk about that. So here they looked at these, and by the way, this, if you guys don't know about this journal, The Foot, this was in The Foot, and The Foot, it's called The Foot Edinburgh. When you look it up, if you go through your hospital library, this is how it'll be listed. This is the Sladen Library through Henry Ford, and right there, that's how this is. And it's a pretty good article, pretty good journal. It comes out of Europe. A lot of articles from this. I think we'll see it again. But anyway, this is this article, and basically what they did was they looked at 2,260 hammer toe articles, which is quite a bit, and 66 met inclusion criteria, and there were 3,878 toes that they looked at inside this thing. Now 3,255 had percutaneous K-wires. 347 had smart toe implants, and 218 had a toe grip implant. And I'll show you what that is in a minute. And then 58 had buried K-wires, one of which we just looked at that buried K-wire. And here's what they found. Well, the overall infection rates were low for all. Okay, pretty good. No infections in this toe grip. And here's this toe grip thing right here. This is an interesting material. This is called PEEK, or it's a polyether ether ketone. It's a thermoplastic. This is what it looks like. They use these for skull implants. This is kind of a cool material, but this PEEK is being used more often. Anyway, here's this toe grip. Here's the insertion, and kind of stays in there. So, once again, I thought we were going to be together potentially. Who is used or is still using a smart toe implant? Because what they did show was that the smart toe implants had the highest failure rate at 20.7%. And that necessarily wasn't a failure of the hammer toe, but it was a failure of the implant, okay? Percutaneous K-wires failed very minimally, and there were no reported failures with this toe grip implant. Pretty thick thermoplastic, so that's not much going to happen to that. Or a buried K-wire, okay? But buried K-wires migrate. Percutaneous K-wires can move a little bit. This smart toe didn't migrate very much. And one of the questions, like I said, I'm not bashing any implant specifically, but has anybody ever had to remove a failed smart toe? It's not easy. It's not easy, and you can kind of make a mess of a digit if you have to do that, which I've done. So I'm speaking from experience. Union rates are not statistically different, but the smart toe did once again have the highest union rate. So it's not necessarily a failure of a fusion of the toe, but the implants can fracture. buried K-wires and percutaneous K-wires, of course, because there's simply a splintage with them and not compression like there is with some of these other devices, their union is less. But does that mean a problem with the toe? We don't know, because in all these digits, the patient satisfaction rates were poorly reported. And that's the one thing. You don't know how they did. Here's the thing about these, why I bring this article up and why I wanted to look at it. The cost of the smart toe and the toe grip clearly are much greater than the K-wires. And here's the UK dollars. And here's what those dollars, once again, this was just last year. This is what these smart toes cost in American dollars in Europe. Could they be, this was 2020, could they be more expensive now? Theoretically. This was an interesting little poster from an ACFAS. I found this online, and this was 2015 from a doctor and some residents in Ohio, in Cincinnati, Ohio. And I won't belabor this whole thing, but they looked at a bunch of different internal implants for toes, and they looked at a K-wire. And, the complication rates were, you have to take this with a grain of salt, because look, they're looking at like 33%, 50% they put in 2 of these striker toe tacks, and 1 of them failed, right? So it's not, right, 2 of these had 33, 1 of 3 of these failed, right? The issue is with the cost of these, right? So these were actually patients that had these implants implanted, and look at the cost of these implants. They really like the Crossroads implant. I have no experience with these, but they put in 140 of these into their patients. There were only 4 more K-wires used by comparison, 144. And I did the math for you. I added all these up. There were 212 non-K-wire hammer toe implants for a total of $374,000. And that's an average of $1,764 per hammer toe, and they spent $360 on 144 K-wires, $360. And I wanted to put this, I don't know if anybody likes Bloodsport, but I love that movie. I don't know if you remember this guy going, okay, USA. But these clearly are, look at the cost of a hammer toe implant. I don't know if you could see my mouse moving, but $1,568 per smart toe versus 1 year ago, $454. Why are they charging under $500 in Europe and they're charging this here? That's just a question I had to ask for myself, and that guy, okay, USA, I don't know if you remember, but that's America for you, right? I don't know why they're, I guess that'd be a question to ask your smart toe rep. If it's profitable there a couple years ago to charge that, why do we get charged $1,568, right? Anyway, here's the analysis. Looked like they were comparable in healing to K-wires, patient satisfaction, but 900 times the cost. 900 times the cost. And what they said, ultimately, tried and true K-wire fixation is significantly more cost effective. Here's an interesting study. Now, this was from a couple years ago, but I pulled this comparative study of intramedullary hammer toe fixation. And what they did in this is they looked at basically how hammer toes did with K-wires versus smart toe versus 10 fuse, which is another type of internal implant. And everything, once again, looking kind of the same. Satisfaction scores are kind of the same. And once again, if anybody needs these articles, you can email me. I'll get them to you. And here's that 10 fuse. There's the smart toe, and there's that 10 fuse. It's another type of it's not, I don't think it's necessarily PEEK if I remember, but it's an allograft. This is kind of funny. Within this article, 3 toes on the same patient had smart toes, and there was a different outcome on each of them. They had union on the second toe, they had a pseudarthrosis on the third toe, and they had breakage on the fourth toe. Okay, and once again, look at that fourth toe. Do you think that patient is happy with that fourth toe? So everything you did essentially to put this hammer toe implant in for cosmesis has been negated with the outcome, right? That was 2015 prices. That was $4,704 for 3 toes, and it's probably going to be another surgery, right? So what's the point of this? I use another type of an implant. You might see one later. I don't mind doing single toes, but come on, do you want to spend $4,000, $5,000 to fix 3 hammer toes, and then you got to revise it? I don't think she's or he's happy with that. The smart toe broke much greater than the 10 fuse or the K-wire within that article, and they noted statistical significance. Are you going to have pain with that third toe? Does that third toe need to be revised? And actually, now that I'm looking at it, and I blew this up and I didn't see it, but the wing is also broken on that third toe. It didn't break as overtly as number 4, but can you see that little lateral wing on the number 3? So you've got issues here. There are positives. Their patients are satisfied more with IM fixation in these articles, and it's just my 2 cents, I assume, because nothing's sticking out of the toe like a K-wire, right? But they noted that patients were unsatisfied or very unsatisfied with K-wires versus the other toes. But how satisfied are you when you got to go back and have another surgery? I don't know. They found statistically significant differences of fusion. The smart toe and the 10 fuse had better non-union rates versus K-wires, but where do you draw the line, right? This study here, it showed that the use of the smart toe and 10 fuse improved outcomes, but there's this cost thing that we're talking about, right? There are likely cases, maybe somebody, a female or a male that has cosmetic concerns that would be better, or there's an infection issue with a K-wire. But of course, once again, if IM fixation fails, it negates the issues of cosmesis, because if you got to go back in, that toe's not gonna look like it did after a revision versus a primary procedure that went well. I really wanted this article to be in English. Research progress of interphalangeal arthrodesis. It looked like it was going to be a good one. It was in Chinese, and I pulled the article, and it sure was, and I can't read this. So, but what they did do was they printed the abstract in English, and their conclusion was interphalangeal arthrodesis is a good way to correct some deformity of toes, but the incidence of various complications can't be ignored, and there's still a lack of clinical research, and I just couldn't look at the rest of the article, and so we don't know what it said. But here's another one in 2020. We're back another year now. We're looking 2 years ago. The role of lesser metatarsophalangeal joint arthrodesis for revisional surgery. And we're not talking about the great toe, we're talking about the lesser toe. And I've heard Sean Grambart speak at ACTFAS. He's a really sharp guy. And he talked about this lesser. Now, here's the article that started all this. Larry Carlock, years ago, this was 2003, discussed his second MPJ fusion. And in this article, there were 4 men, 11 women. He did end-to-end resections on 8, curettage on 4. He didn't do any bone grafts. And there were some supplemental procedures that were done, but he had a 91% successful fusion on his second MPJ. And he had good to excellent outcomes on those 10 of 11 feet. And there was a second toe attempted fusion that he had to revise, and there's that second toe doing better. This is in Sean's paper, so this is clearly someone that had looked like a Weil osteotomy with a headless screw, and that looks to me, anyway, like an AVN of the head of the second. And so he opened it up. He removed all that bone because of an AVN. He used this was kind of cool. This is an ulnar allograft from AVN. It kind of fits right into that space, and he fused it. And yeah, despite that being an allograft in a small space and no compression, he just did a dorsal plate. He got good fusion at 6 months, and it looked pretty good. And my thing was, hey, could you have gotten a calcaneal autograft to put in that space? That would have been my choice versus using an allograft. But hey, I mean, to each his own. Here's that second toe. He said he raised it a little bit, owing to the patient wanting to wear a shoe with a 1 to 2 inch heel. Here's another picture from his article. And he's got this patient clearly previous, maybe a scar for an Austin, I'm not exactly sure, with a lot of arthrosis. And if you remember my lecture from last year, right, this one could have probably used a fusion right from the get-go, right? This is that exactly what I said. Osteotomy and arthrosis, because this was a pre-arthritic first MPJ. But look at these toes, right? They're clearly, you got a lot of transverse deformity. It looked like there was also a little bit of an AVN of the fifth metatarsal head, not a little, a lot, from a previous osteotomy. That didn't work out well for whoever did that surgery. And here's what he did, though. Kind of a not very symptomatic great toe, but fusions of the second and third MPJs to straighten out those transverse deformities. And this was 6 months post-op. Here's that pre. And what I wanted to mention, and once again, this was the post-op, and here's the pre-op. Really nice correction. I would have dealt with this a little bit differently. I'm going to talk about that in a little bit. I'm a fan of the lesser MPJ fusion, but I typically combine it with another procedure. If I was with you guys, I would have asked, what does anybody know what I'm talking about? What other procedure? And it's a first MPJ fusion, and here's the famous Mike Coughlin talking about concomitant first and second MPJ fusions. And I think this is a great surgery. Here's a first MPJ that was clearly arthritic, giving the patient an issue. A bad second MPJ that after someone did a while osteotomy, it was more arthritic, and this was fixed with a first MPJ fusion and a second MPJ arthrodesis. This is one of my patients, and I put the question mark up there. I think she was in her 70s. I meant to fix that before finish my lecture. Sorry about that, but she was in her 70s when I met her. Rheumatoid. You can look at the significant bunion. You can look at the severe MPJ, lesser MPJ issue. And I fused her and I did a little dorsal plate, and she did great with this. She loved this. She's not with us anymore. She was a heck of a lady, but I saw her for nail care until the end of her life, and she had this for probably 4 or 5 years and never gave her an issue. She was doing well. So in the right circumstance, and my point with showing this was, as long as the first MPJ is fused, the second MPJ does very well being fused. All you do is line it up with the digit on the first, and you roll over it and you do well. This was an article from 2012, just going back on a little bit of retrospective on lesser MPJ fusions because we were talking about them here. And this was a retrospective review of 31 lesser MPJ fusions, 3 different surgeons. They had a mean time of 10 weeks to good clinical union. They had non-weight bearing for about 4 weeks or so. They had pretty good results, some non-unions. There was a little infection, statistically significant pain reduction, and improved digits. So first MPJ fusions, lesser MPJ fusions were working well in 2012. They're working well now. Here was a little thing from their article, a couple stacked staples with a plate on the one side, stacked staples with a K-wire on the other. That K-wire is percutaneous. And they had really good outcomes, showing that the preoperative pain doing very well, compared to postoperative pain. Pre-op pain, of course, didn't have a blue line at the nun because they hadn't, had surgery yet. But compared to mild, I'm sorry if I confused that a little bit on everybody. What I meant was that nobody had no preoperative pain. You can see on the nun, majority had moderate, and some had mild and some had severe. And you could see, all patients clearly had improvement in pre-op to post-op pain. Here's another article that I thought was really good. Ideal implant for hammer toe repair, and this was a systematic review. Here's the article right here, and These, of course, are the best because they look at high-powered studies, and what they found was that intramedullary devices were clearly developed to reduce problems with K-wire fixation, essentially in PIPJ fusion. And the purpose of this article was to compare the outcomes of the novel intramedullary internal devices versus K-wires. They looked at 92 studies, 5 of them met the inclusion criteria, and these were the few that they looked at. The 5 articles had these implants, the Stryker Smart Toe, a couple other ones. We've looked at that 10 fuse before. These were different type of materials. Allograft was that 10 fuse, and then stainless steel and titanium and a nitinol alloy. And here were the results. They had promising results in union rates comparing the internal implants versus K-wires. We know this. However, the internal devices seemed not to present advantages in clinical parameters such as pain levels, patient satisfaction, and foot-related or surgical outcomes. So once again, they're wondering, we're using these, they're more expensive. Do they really have major improvement rates? And I just want to go back to that for one more second. That was the portion of it from the paper. So once again, for a cosmetic concern, maybe, or a single toe, maybe. But, once you start wrapping up 2-3 toes need to be fixed, and the cost of these to put them into subsequent digits, multiple sequential hammer toe surgeries, it's a lot of money. This was a great article. I'm really happy. This was from the Weil Institute. Look, this got published in Journal of Foot and Ankle. Foot and Ankle International. And to have podiatrists, get into that journal is a heck of a kudos. And Adam Fleischer, he is one of the guys that graduated from the Weil Fellowship, and he's still there. Super sharp guy. They wanted to see what makes hammer toes fail. What are the risk factors? And they looked at their own patients retrospectively, 311 toes done. And they looked at multiple techniques, and these were all the techniques from an arthroplasty to an interpositional plasty with a silicone implant, PIPJ fusions with wires, PIPJ fusions with implants, okay? And phalangeal osteotomies. The other techniques that they looked at were flexor tenotomies alone, middle phalangectomy, and a syndactyly. That was the other. And they wanted to look at, what techniques. They used these other procedures for MPJ correction. And what predictors, if there are any, that lead to increased hammer toe failure? Here's all those surgeries. Here's that little Swanson implant. That's a shortening phalangeal osteotomy, basically 2 transverse cuts in the central of the phalanx. One of the doctors there clearly likes that. And this was interesting to me. What leads to greater hammer toe failure? Well, there's a couple risk factors, and one of them was that if you have a transverse plane angle deviating the hammer toe at the MPJ, there's a 1 degree hazard ratio, and that's pretty significant. Operating on the second toe versus the third and fourth toes led to more failure. Use of a phalangeal osteotomy to reduce the PIPJ was a greater failure. And using a less common surgery, which is one of those others, a syndactyly or something, that was also a risk factor. You lowered the risk factor when you did a concomitant first ray procedure, if you fixed hallux valgus or hallux rigidus, and I think that's something we all know. Here's that part of the article, and once again, one of the things that lowered the hazard ratio was to do a concomitant first ray surgery, but the total transverse deviation and operating on the second versus the third and fourth caused these hazard ratios to go up. And basically that hazard ratio is if in a study a treatment group dies or if something happens to something at twice the rate of the control group, the hazard ratio is 2. And so you can see that as things go up in hazard ratio, the worse it becomes for the risk factor. Okay. Final article in 2019. One of the that final article in 2020 was that Smart Toe implant from the foot. The final of 2019, so I didn't look just at 2 years. I wanted to include this. They looked at percutaneous flexor tenotomies for foot ulcers, and I know this isn't necessarily a hammer toe issue like we've been talking about, but diabetics get ulcers at the tip of a hammer toe, and I thought this was interesting. This was from the Netherlands, and how well does a percutaneous flexor tenotomy do when you've got a distal ulceration? And they looked at how effective it was. They had 101 feet, 265 tenotomies, 84 were therapeutic, and 17 were prophylactic, okay? And here's those digits. This is the tenotomies that they did. This was at the base of the toe, centrally, planarly. Those were clearly prophylactic. That patient did not have ulcers. But here's what they looked at, and here's what they saw. Of the 85 therapeutic hammer toes that were done, 95% of those ulcers healed, and the median healing time was 27 days. I love flexor tenotomies for distal diabetic hammer toes. There were 4 infections, 1 amputation. Of the 17 prophylactic, 2 ulcers developed, and that amputation of the therapeutic ones had an infected ulcer at the time of the tenotomy. So that patient waited a little bit too long to have it done, but pretty good. Does anybody here, I heard Dr. Tom Rukas lecture on this years ago. Does anyone do an FHL tenotomy? You'd think that that's such a no-no, but in this article, they did 11 therapeutic and 4 prophylactic transections of the FHL. And, you know, honestly, that stuff gets caught in the tissue at the plantar aspect of the first MPJ and also at the masternode of Henry. This thing is held up. So in a neuropathic diabetic, it doesn't hurt too much to transect the FHL. They don't have an issue with it. Here's another article showing effectiveness of percutaneous flexor tenotomies for distal diabetic foot ulcers. And in here you can see, look at the digits that were tenotomized, a bunch of hallux. So this is transection of the FHL. It's not the worst thing in the world to do. Look at how quickly an FHL transfer would heal versus a Keller or something like this. There's no bone touched in these procedures. So really good thing to do for a distal ulcer on a great toe is to cut that FHL. Here's FHL, FHB, tendons transected. So let's briefly, I'm almost coming to the end here. Let's talk about the transverse plane hammer toe for one more second. This is that article, the picture from Dr. Grambart's article that I mentioned I would have dealt with this a little bit differently. And nothing wrong with the second and third MPJ fusions. He did a really nice job. Once again, here's that hazard ratio showing that as you increase the transverse deviation, and if you've got this combined with a transverse issue on the second toe, the hazard ratio goes up significantly. Once again, gets worse. I'm going to show you a quick, brief article. I'm only about 40 minutes in, so I'm doing good. We'll have time for questions. But this patient came in to me, and she's a 77-year-old female, and she said, my toe won't touch the ground. And this was her clinical picture. So, you know, I'm sure you guys, when you see something like this, this is complicated, right? I would call those transverse plane hammer toes. Here's what her initial x-ray looked like. I'm not a fan of, you know, I like fusions, and I'm not a fan of hemi implants like this. But she's got one, right? We've got to deal with this. Her hallux is in the air. Her second and third toes basically are tucked. The second toe is tucked completely below the hallux. And this is her lateral. And you can see we're dealing with a little bit of a problem here. If I show you the lateral view up close, you can see that the implant has nearly completely eroded the plantar aspect of the great toe. So, you know, you're looking at this, and her issue is with this digit. My toe won't touch the ground. And when you look at that, you're thinking, what do I got to do, right? 77 years old. So, and that's leading to that, right? Well, you know me, of course, I like to dig into these patients, and I had her go and get her x-rays from the previous surgeon, and here is her, and I'm sorry you can't see this that well because these are photos of a printout of her, like on that kind of paper. It's not white paper. I think it would have come out well, but like the shiny paper. So these didn't come out great, but you could see the hallux rigidus there, right? Already a little bit of a deviation of the second digit, and for me, this would have been a first MPJ fusion all the way. Already a subluxing second MPJ, the cardio protection of a fusion, and you know me in fusions, the baseline, how well fusions do would have made me fuse this. But anyway, here's her picture from the lateral view. Here's what she had done. Here's it from the lateral view. And you're not seeing things. I'm going to flip that over. She had an Aiken on the other side, and that's what the staple looks like. So you already know what kind of surgeon we're dealing with here, right? A person that just doesn't put stuff in the right place. I would argue that, even though I'm not a fan of these, that looked like it was inserted fairly centrally. I've seen some BioPro implants where somebody's not paying good attention, and that hinge that's on the back of that is aimed right at the plantar aspect. If you can put one of these in, I'm not a fan of them, but it was put in fairly correctly. But my issue is what happens to them long term, and this is what happens. Now you got this. And despite this, no metatarsalgia, no first metatarsalgia, no lesser metatarsalgia. So here's the thing. What do you do with this? We got to get her toe down, and to get her toe down, you got to move her second and third out of the way because you're trying to park 3 cars in 2 spaces there, essentially. And, this is tough. So briefly, I love the Stainsby procedure, and I am going to just briefly tell you what the Stainsby procedure is. I use it in cases where there is no lesser metatarsalgia, and this essentially, for me, I think of the Stainsby as a metatarsal head resection, power without resecting the metatarsals, without resecting the metatarsal heads. And I'm all about leaving the 5 metatarsal heads there when you can. So this is an arthroplasty of the joint. And if you don't take the met heads away, well, what do? Well, you remove the base of the proximal phalanx. And we all know one of the issues with a phalangeal base resection is that you get a floating toe, because when you remove the base of the proximal phalanx, you lose the insertion of one of the flexors, right? And so what do? Well, the Stainsby is a resection of the base of the phalanx, but you transect the extensor, the EDL, and you tie it through the space to the plantar tissue. And that negates the loss of the flexor insertion. And it's great. And I love these. And I've mentioned Baruch before, Baruch's book, and Baruch loves these too. So if I'm in his company, I'm in really good company. This is another article. They modified their Stainsby a little bit, Dr. Concannon in Ireland. And essentially what they did is, instead of tying it internally, they passed a Keith needle through the EDL. And when they passed it through the space, they pulled it through the plantar aspect. And they tied it down under a button. And they let it scar through there. Same thing, basically. I simply stitch mine to the plantar tissue inside. And it's great. And this is from the article, First MPJ Fusion. You can see the resected base of the second digit on that image D. Pretty powerful. It works on rheumatoids too, right? Let's say you don't have any major rheumatoid nodules. Everybody, automatically a rheumatoid, you're thinking that you need, of course, a first MPJ fusion and lesser metatarsal head resection. But what if they don't have metatarsalgia? What if it's just dislocated toes? Well, this works. Look how nice you can get, and all your 5 pedestals are still there. Look at that picture on the right. I love this procedure. This is resection of the base of 2, 3, 4, and 5 with the extensor digitorum longus tied down to the plantar tissue, pinned. And the way the Stainsby works is, and I wanted to be able to show you this. I didn't have one recently to take pictures, but essentially you're making the incision over the MPJ. You're tracing the EDL tendon back a little bit. You're transecting it. You're rolling it back. You're exposing the tissue of the joint. You're transecting the proximal phalanx. Then you take the EDL and you stitch it down. You've already driven a K-wire out and you've retrograded it. And then once that tendon is down, once you've passed it through, you essentially hold it down while you're antegrating your K-wire back through. And you essentially want to stab, if you can, through the transferred EDL tendon, right through that with the K-wire and into the metatarsal head. And that's how you hold it in place. And it does great. And so, this patient, what was I going to do? Like, do you go get a graft on her? She's 77. Like, this is kind of troublesome. And the phalanx had eaten through the implant had eaten through the whole plantar aspect of the proximal phalanx. What do you have to do? Graft that? And she had no problems with the pain under the first ray. It essentially was a deformity where the digit would not touch the ground. And so here's what I did. I do use silicone implants in certain cases, and I put one here. So basically what I did was, and you can't see it very well on here, but I cemented the proximal phalanx and I made it flush. And once I cemented it, we kept it distracted. I did some other work. I did my Stainsby's, and there's my pins through my second and third digits. And then what I did was I re-drilled the cemented hole, the rebuilt proximal phalanx, and I inserted a silicone implant that was going to let that digit sit. It was going to not take as much length away from the digit. And here's what it looked like laterally. You can see my hinged implant in there. Here's what it looks like postoperatively. You can't really see the cement very well in the proximal phalanx, but that's what it was in the air. Now it's on the ground. That's with the pins out. Everything stays. And here's what her foot looked like after. And that was one of the early post-op pictures. She was swollen, but you make it from that to that, and she did really well. And so this Stainsby, I use it when it's appropriate. No lesser metatarsalgia. Of course, if you have metatarsalgia, you have to do a shortening osteotomy. And once again, with a fused great toe joint in a rheumatoid arthritic patient, a lesser metatarsal head resection works very well. I'll use threaded K-wires to not let the digit suck back, and I pin those threaded K-wires. I run that threaded K-wire out. This is a really long, one of the long threaded K-wires, not a 6-inch. They have foot-long threaded K-wires. And I throw that threaded K-wire all the way up that metatarsal into the cuneiform, and it holds them, and I bring them back to the OR to take those K-wires out. You don't have to do anything major. You just got to sedate them a little bit, and you've got to back those out with a drill because they're threaded, and they do great. I don't like pan-metatarsal head resections. A fusion is much more stabilizing for the first ray. But if you don't have any lesser MPJ problems, these Stainsby's, they really work well. Think about it when you don't need to. There's no lesser MPJ issue. Basically, it's pain below the lesser metatarsal heads, I should say. There is a lesser MPJ issue. There's a transverse deformity or a crossover deformity of the toe, and you want to maintain that metatarsal head, and they work really well. And I think I forgot a thank you slide, but I want to thank everybody. I made my time. We've got some time for questions, and I'll see you on Zoom, and then I'll see you Saturday. Thanks again.